Why is it important?
Yes.
Make sure they're not dehydrated.
Right. Well, you want to know where they're at in terms of fluid that they're taking in and how it correlates with how they're presenting. Right? Are they edematous? Are they in fluid volume overload? Are they in fluid volume deficit? You don't have anywhere to go for that if you don't know how much they're taking in. What items count as fluids, Carmen?
Anything that melts,
You're right.
Liquid at room temperature.
Yep, anything that's liquid at room temperature. So, any water, soup, pudding, all of those things count as fluids. How do we record fluid intake here?
care tracker.
We hope. Who needs to know when a resident's fluid intake is less than desired? If someone's not taking in enough, who do you want to notify?
The doctor, the nurse practitioner, your
Yeah.
unit manager,
Yeah?
next shift,
Yeah?
Nurse practitioner.
The resident themselves.
if they will.
And the dietitian.
Yeah, we can-
And Sharon if you want to. No.
No, we have to go to,
How do we let them know? How do you notify them? What are some methods that you use?
email, call them,
It is most typically here in an email.
self-them.
What is dehydration and what are the signs and symptoms?
Skin temperature.
Anybody, help them out.
My brain cells on there.
So dehydration itself is a reduced total body fluid volume, right? So you don't have enough water in your body to keep your cells and your organs and your functional systems going. And the signs and symptoms, we'll go through a list of them later, but they do include skin turgor, and that's always the first one everyone thinks of. But one thing I want to make sure you know is in the elderly, you don't check skin turgor here. Because every elderly person, you're going to pinch and it's just going to stand there. It's just kind of, just like you wake up now with this wrinkle in your cheek and it stays there till 11 o'clock, you're sliding downhill. But you want to check at the clavicle. So you want to write your note that their skin turgor is brisk and, they have no tenting at the clavicular area, left clavicular area, right clavicular area. That's where you want to check that. So thank you, New York State Department of Health. And we mean that because what they come in and look at is in the interest of providing better care to all residents, and what they find and identify and tell us about, we have the opportunity to improve. That said, we would certainly prefer to be catching these problems ahead of time and not having them pointed out by our friends. So we'd rather be proactive than reactive. We'd rather know something's coming than be told it's already passed. So the problems that they found during our survey were that we could not prove that we had provided enough fluid intake to keep residents hydrated and healthy. And the famous sentence on the right, not documented, not done. Not documented, not done. So you could know that you offered that resident fluid every hour and they declined it no matter how hard you tried. But if you didn't write that down, you're not going to win that argument with a surveyor, especially if the resident has symptoms and is clinically dehydrated and has a negative outcome. So it has to be documented. Documentation is important. Information gathered about residents at risk was not communicated to the people who needed to know. Our care plans did not always state the problem, at risk for fluid volume deficit or dehydration, and what our plan was to meet that resident's needs. And unit managers will say, why do I need to be on top of these care plans? I have a million things to do. It's not like the CNAs and the nurses sit and read the care plans. That's true, but they're exercising nursing process. So by the unit manager identifying the problem list for that resident and putting a problem statement, goals, and approaches, it's coming through that process that they come up with approaches that they then communicate to the staff to make sure the plan of care happens. So that whole process needs to take place. And when the surveyors come in, what do they start with? A care plan. That's all they care about. What's your care plan for this person? So it's very important to keep it up to date. Our documentation of fluid intake is incomplete. Important information about residents fell through the cracks. In addition to not documented, not done, this is serious because we can't solve what we fail to identify. If we don't know there's a problem, we can't do much about it. Information is shared through care planning. We may be looking at residents for fluid volume deficit when the actual problem is not all their intake is being recorded. We'll go over the fluid measuring policy that's been revised, and what we've all agreed upon is less than 1,000 cc's in 24 hours is not what we consider clinically significant. We're looking more at less than 3,000 cc's intake for 72 hours. But if we monitor that and we come up with a list of 12 people, more than likely here, 3 of them really are at risk and have a problem, and the other 9 are, as I say, fat and happy, and we just haven't recorded all the fluids that they have. All the ice their husband gives them, all the lemonade they drink, all the Pepsi they drink, all the water they get from their sinks when they self-propel themselves, what they drink at dialysis, and other things. We want to make sure we're capturing and recording all the intake we possibly can so we don't have these people as frequent flyers on the low fluid list when clinically they're not dehydrated and they're not having a problem. And there's a potential for negative outcomes if we don't do this. So who's at risk for dehydration and fluid volume deficit? Residents with altered thirst. So that can be related to focal central nervous system lesions due to a stroke. Hypodipsia of aging, that means no thirst. The elderly don't feel a thirst response. They don't feel thirsty even when they're behind in fluid, so it's up to us to offer them. Just like it will be 90 degrees out and they'll have a sweater and they won't realize they're overheated. So we have to watch that. And then medications, there's a table in the handouts and in the presentation, and also one of your handouts was a more detailed list. Decreased cognitive function. Delirium is one sign of acute dehydration. Delirium is new onset or worsened confusion. When someone's really out of their head and maybe hallucinating and having delusions, that can be a clinical sign of acute illness or dehydration. Bless you. Dementia. If a person is confused, they're not going to think to drink enough. And so we need to make sure demented residents are drinking adequately. Depression, the resident's not motivated to drink. Sedation, watch med changes. You may have a resident who typically is no concern with fluids. They drink adequately and they do well. But if they just started Zyprexa or some new med, or a new pain med, and they're a little bit groggy, keep an eye on them because they may not be taking enough in. We have to think ahead of time, be ahead of ourselves on these situations. I've seen residents go into A and became really sick, even though maybe they were an independent resident. Come back on Monday, they've developed 2-stage 2s because they go to bed and they're sick and they're down with a fever and nobody thinks about turning that person because usually they don't need it. But we've got to think when something changes for them, even in the short term, to be proactive that way. So that person needs help with positioning, they need help with fluids because they're not taking care of any of those needs right now because they're too sick. So we want to be thinking about that. Psychosis and paranoia. When you have a resident who has dementia with psychosis, that person who thinks we're poisoning the food, we're poisoning the water, we have to do something about that because that's a real problem, getting them to take enough. You know, is there a trusted staff member that has a good rapport with them that they'll drink for? Do we need a psych consult? Do we need to make some med adjustments? What can we do about that? Increased fluid losses. We have a benchmark of 3,000 cc's for 72 hours for a person, but that is really a fluid minimum. At the very minimum, you'd want someone to take that much in. That's really not very much. Some of us would drink that in a shift time. So when you have additional fluid losses in terms of diarrhea, fever, vomiting, a significantly draining wound, respiratory distress with an elevated respiratory rate where with all of those exhalations they're losing incidental fluid, diaphoresis when they're really sweaty, or a specialty airflow mattress, a kind of surface for a skin problem that's constantly heating the person up and their skin's moist and then it's cooling them. They're always having that evaporation from their skin. Things like this increase the person's fluid need. So if Jody was calculating the amount of fluid this person needs, where the average person might need 3,600 for 3 days, this person might need 5,000 because they're losing more than that other person. So once you see these changes in someone's condition, you really got to be thinking, boy, they're going to run into trouble with dehydration. Anyone with limited oral intake is at risk. Dysphagia, residents with swallowing difficulties, these are always the residents that are behind the fluids and are the hardest people to get the fluids into. And a lot of times their fluids are thickened. You see number 5 down there. If they have nectar thick, honey thick, pudding thick, well, I don't think they satisfy you when you drink them. And they don't like them, so they don't drink as well. We do have a Fraser free water program where some of our residents, even though their meal fluids are thickened, they can have regular water in between. And one reason for that is that First of all, statistics show that mechanically altering a diet doesn't necessarily prevent someone from aspirating. Someone who's an aspirator is going to aspirate. And not all aspiration leads to aspiration pneumonia. It's only when it has bacteria with it. So they actually know now that it has a lot more to do with oral care. If your mouth is heavily colonized with bacteria, your mouth's not clean, if you aspirate something, it's bringing a bunch of those bacteria with it, and you're more likely to have aspiration pneumonia. So oral care is very, very important that we make sure that happens. And in addition to making a person less likely to have aspiration pneumonia, having a moist and clean mouth increases a person's appetite and their willingness to eat and drink. So we want to think about that. Fear of urinary incontinence. If I drink, I'm going to have to pee. If I have to pee, I'm going to have to ring the bell. If I ring the bell, I'm going to wait for 20 minutes. So they don't want to drink. You see those people. So we want to be sure we're recognizing that so we can address that with them. Inadequate tube feeding volume. That's a big deal. We shouldn't have anyone dehydrated on a tube feed because we have 100% control over what goes into that person's system. We have the feedings and we have the free water flushes. But a thing for nurses to think about is if that person's going along and they're doing really well on the flushes that they have, if they develop a fever of 102 degrees, they need more fluid than they normally do, and they only get the fluid we give them. So we want to increase those water flushes for a while so that we make sure they're getting enough while they have an increased need.
Can't we increase it anyway? Or are we only allowed to give what's?
You're only allowed to give what's ordered. In a tube-fed person, the free water flushes have to be ordered. So just to be sure, so I would ask for that and get them upped. Limited mobility. If you can't get to the fluids, you only get what people give you. And the same with the need for feeding assistance. When we have to sit down and help someone, then they don't get any fluids unless we're helping them with them. So we have to remember that. So examples of medications that may increase dehydration risk. This is a simple table, and I spelled it out more with the names of medications for you in the handout. And I thought it was really interesting because we all know diuretics do this. We all know Lasix, Bumex, hydrochlorothiazide. We all know those meds are going to cause a person's body to excrete fluid. But we don't think about the other ones. The ACE inhibitors, the angiotensin II receptor blockers, caffeine formulations, which not many of our residents have, diuretics, laxatives. You give someone a laxative and they have loss of stool, laxatives cause your body to pull fluid in from your system into your GI tract to soften the stool so you can go to the bathroom. So you have fluid losses with laxatives, and especially if they cause diarrhea too. Lithium. A side effect of lithium is polydipsia, wanting to drink all the time because it makes you more thirsty. Theophylline preparations for breathing, tricyclic antidepressants, and selective serotonin reuptake inhibitors, both of those for depression. And vitamin D and calcium formulations. Who thinks about those adding to fluid losses? Now typically, we're not going to DC these meds for these residents. We're just going to be aware of the fact that they're on them and monitoring them for fluid losses. Although our citation was due to the fact that we had a resident who was clinically dehydrated, labs were grossly abnormal, BUN I think was over 100, and we were giving her IV fluid, but we continued giving her Lasix just as it had been ordered. Do you want to keep giving a resident who's losing fluid and who's clinically dehydrated a med that causes them to excrete more fluid? Maybe you do. Maybe you do. Because if the resident is riding that balance where if you hydrate them, they have a risk to go into failure, you're going to be watching that. But
You chart it.
yeah, you chart it and you want to be fine-tuning it. The point is, no one documented even noticing it. And we want to make sure we're looking at it and say, well, let's hold their Lasix for 2 days and monitor them. Monitor their lung sounds every shift, and we'll hold it for a few days and see how they're doing. Or we'll cut it from BID to once a day, or we'll give it every other day. You just want to show that you're aware of it and that you are monitoring it and making adjustments, not that you just missed it. And the thing that concerned me is that detail was missed by everybody at every level. It was missed by the nurse practitioner when the IV was ordered. It was missed by the charge nurse when the order was carried. It was missed by the med nurse who kept on giving the Lasix. It was missed by the unit manager. So at every level it was missed. It was missed by the dietitian. And what we need is for one of us to snag that and pick it up. You know, it doesn't matter who it is, just so someone asks the question. And if you're giving meds and you know this person's dehydrated and you know they have an IV, there's nothing wrong with asking, you know, are we sure we want to still give this? And maybe you'll get some rationale from that nurse practitioner, and you raise your eyebrows, and that's come up that some staff have said, well, you're going to make them angry. Well, first of all, it's in your delivery. A lot of it's in how you communicate it. I just want to make sure you're aware that she's still getting Lasix twice a day. And if it makes them angry, for one, that's their problem. And for another thing, until we have that free exchange of information and we're collaborative and collegial and we can communicate that kind of stuff, nothing's going to change in the culture and the environment. So we have to have that accepted and we have to keep on doing it. And it's everyone's job to notice these things. So whose job is it to pay attention to this stuff? Yep. So you see the sick person equals the waterfall. Just get that association in your brain. Anytime a resident's sick or has a change, everybody has to immediately think about fluids. She's throwing up today, what's happening with her fluids? She's got a fever, what's happening with her fluids? She's weaker in the ADLs, what's happening with her fluids? Your brain immediately wants to go to that, all of us. And CNAs need to learn this too. And what I'm telling all the nurses, as you learn this, you want to go out and give that information to your CNAs and encourage them to be documenting every bit of fluid intake and what constitutes fluid intake, and to let you know, because they're often the first people who see changes at the bedside, that these changes have happened in residents. So signs and symptoms when you know something's not right with a resident. Changes in ADLs, more assistance needed. What was one of the risk factors for dehydration? Limited mobility, can't get them fluid. So besides thinking that you need to send a therapy referral because they need more assistance, you need to think about the fact that they need more help eating and drinking too. Change in mental status, like I said, if they're regularly confused, that can be hard to tell. But if they're usually pleasantly confused and now they're combative or negative or paranoid or having hallucinations, those are signs of delirium and you want to notice a change, or particularly if they're alert and oriented and now they're confused. But what do we tend to think? UTI, they're more confused, their urine's dark, they've got a UTI, and how many times do we treat that without even really looking? Or if you just push PO fluids for a few days and monitor them, you might see that it's more that they're dry. Constipation, hard, dry stool, decreased urine output, and that's something to teach the CNAs. If the resident's incontinent and they're changing them, and usually they have 2 saturated 10s every shift, and tonight they didn't even have 1, we want to make sure they tell you that because their output is falling off. We want to make sure we know. Dry mucous membranes, the skin, eyes, nose, and mouth. In an extreme case, they wouldn't even have tears if they cried. Dizziness, faintness, and postural hypotension, which is what, Michelle? Orthostasis? What is it?
What do you mean, what is,
Low blood pressure.
When?
Oh, when you move.
Yeah.
stand up, sit up, lay
Mhm.
down, roll
And-
from one side to the other?
Absolutely. So one thing we're talking about are nursing orders. Not every order has to come from a provider. There are things that we can choose to do as nurses using our nursing judgment. If we think a resident's dizzy and faint and weak, and we suspect that they're dehydrated, we can do a lying, sitting, standing blood pressure on our own. We could stick it in the MAR for a few shifts, for 3 shifts to keep an eye on someone when we put them on the report. Or we could even check it once. And that's a really good piece of the puzzle that you're reporting to a nurse practitioner or a doctor, that not only are they not taking sufficient amounts in and their output is decreased, but also their orthostatic blood pressure dropped from 140/80 to 90/60 and they were dizzy. So all of those things help that provider put the whole picture together. We have to use teamwork so they know all of that information. That's going to help move their decision from treating it as UTI to treating it as dehydration. Tachycardia, a pulse over 100, that's abnormal, weakness, and a weight loss of 3 to 5 pounds over a short period of time. And the short period of time is very vague, I know, but this is even in professional literature. They say a short time. No one will pin it down to a length of time. But what I say is, dependent upon the condition of that person and how often they're being weighed, if there's someone who's so tenuous that they're being weighed once a week, you want to look for that much of a change in a week. If there's someone who's being weighed once a month, you want to look for that much change in a month. And The MDS will catch if they've lost 5% of their body weight or 10% of their body weight. But how do people lose 20 pounds? 2 pounds at a time. So we want to notice those trends before we get hit in the head with the fact that they've lost a significant amount. And when we do weekly weights, when we do daily weights, when we do twice weekly weights, we're not just doing it to torture people and have them do extra work. We're really doing just weigh them and don't do anything with the information. The whole point of doing it is to compare this weight to the last weight, and what's that information telling us? That's why we're trying to get it. That's why we're measuring fluid. What does measuring the fluids tell us about the person? If we don't put it all in, it's all for nothing. They say about computers, garbage in, garbage out. They give you very good information. We can run a lot of reports if everything that's pertinent is in there. So communication is key at every level. And the CNAs are responsible to observe daily meal and fluid intake, skin, urinary output, BMs, confusion, behaviors, and they would notify the med nurse, the charge nurse, unit manager, or supervisor. Do they have to let all of them know? No, just one. There's a chain of command. If you're the med nurse and a CNA lets you know, nothing shuts CNAs down from giving people information more than nurses, and the nurses don't do anything. You know, I told her 3 days ago she didn't do anything. So they'll stop telling you. So you've got to be responsive. You have to have that rapport and that respect with your CNAs that when they see a change and they let you know, even if you're just giving them the rationale for why you're not going to change something or you do something about it, that you have heard what they've said. And that you're going to pass that information up through the chain of who needs to know it. It won't end with you. Med nurses evaluate with each med pass. You have lots and lots of meds to give and you don't have a lot of time with each person. So you have to be good at incidental assessments. I compare it to being in line at Walmart and checking out people's flaky diabetes labels and, you know, that they have eczema behind their ears and all that stuff. You got to be able to give somebody pills, talk to them, observe how they're breathing, observe their ankles, observe their skin just for those 2 minutes that you're in there. And noticing a change with people that you see day in and day out. And also what I say is, can you be on top of 40 or 50 people every shift? No. But you better know who your 3 sickest ones are. Know who the sickest ones are that you really have to focus on the most. And then try to pick up if anyone who's been just perfectly fine is showing something new. Charge nurses need to document, notify the unit manager, the nurse practitioner, and the doctor. Unit managers or their designee, they can assign that to a supervisor or a charge nurse. But we need to assess the resident, document, notify the dietitian and the interdisciplinary care plan team. And the supervisor and any of you can place a resident on shift report. There's never any harm in putting someone on shift report. Even if tomorrow everyone decides they're okay and you can take them off. At least that's one way to know they're going to be assessed and documented on for the next couple of shifts. So that you can just check on them until they're out of the woods and we can intervene. And assess, document, email the unit manager and or the director of nursing. Documentation, we already said how important that is. Not documented, not done. So CNAs are documenting intake, output. We rarely do specific output in long-term care because it's just really hard to get and we don't usually use the information for anything. But even if it's just noticing that they're using 1 incontinence pad instead of 3, just getting the general idea. BMs and behaviors. Med nurses should notice med changes, PRN meds given, and the response. Did you give a PRN Lasix? What was the response? What happened? Changes in condition. Charge nurses, assessment, changes in condition, notification of the doctor and the nurse practitioner, orders received. So you see where this is going. Unit managers and supervisors, assessment, notification of the dietitian and the interdisciplinary team, results of investigation. We want to investigate. Those intake CCs and the percentages taken in, we all need to notice, do they correlate with the condition of the resident? If it says they've had 1,200 in for 3 days, but they're fat and happy, then that's probably not really what they had in for 3 days. But if they're showing signs of dehydration, that probably is. And we don't even want to have to investigate people who really had enough to drink because we want to record what they get. If they come back from dialysis and you know they take 240 cc's with them, ask them when they come back and put it in the system. Put things in the system. Approximate the number of ice chips the husband gave her and put them in the system so we account for what the residents are taking in. And Care Tracker works well for this because we can use alerts and the resident profile and task to communicate things that we put into place to the staff. And we can run great reports from it. So what's in an email? We all agreed that the way we communicate that there are insufficient fluids, typically it's the night shift here, runs the reports on the less than 3,000 for 72 hours of fluid and sends emails to the dietitian, the unit manager, the DON, the nurse practitioner, or the doctor. But I compare it to antibiotic notes. What do people tend to say when someone's on the report for a UTI? Continues on antibiotic with no adverse effects. What does that tell you? You got to address the infection that the person has. If they have a,
Or the underground.
yeah, if they put if they are on the antibiotic for a respiratory infection, what do their lungs sound like? Are they coughing? Are they productive? What are they bringing up? It's not enough just to say the antibiotic is causing no negative effects. That's not the reason why you're charting on them.
Is it causing positive?
Yeah. So we get the same thing with these fluid emails if you could read them. So it might say, Sadie took less than 25% of meals today and drank twice. What does that tell Jody? Not much. You know, she gets that information, she still has to do all of this searching, and she's got people in all 3 buildings. We want to tell the whole story. So you want to write a note that helps others prioritize the problem, give the backstory. So with the same resident, you could write, Sadie took 25% of meals today, stated, I went to my daughter's for a big Sunday dinner yesterday, I'm just not very hungry today, usually consumes 75% of her meals. What does that do? That tells everyone that this was an unusual event that she took 25%. It's not an everyday thing. And her skin turgor is good, her mucous membranes are moist, additional foods were offered with MedPass, but she declined, continued to monitor, yada yada. Put on shift report, whatever you want to say. But that gives the person who gets that email much more information on who they really need to be worried about and who they don't. Because they've got to be able to prioritize. And if the opposite were true, if she took 25% and didn't drink adequately and she had a fever of 101 and comfort care was signed or whatever happened, you want to have that in the note too, whatever tells the story. Or they don't have a lot of recorded intake, but they are known to have lemonade in their room or soda in their room or whatever it is, and they have no symptoms. Nursing policy, you can't read it there, but it was one of the handouts, and the main thing I want you to be aware of is that we're no longer focusing on 1,000 cc's for 24 hours. I'll read this. Most clinically significant when you get to 3,000 for 72 hours. So that's what we're looking at. However, nights will continue to look at it every night because it's just like the BM list. You're looking every day. And if someone's in their 3-day cycle, you might see that person 2 or 3 days in a row on the list, but you're expecting that. But at the same time, you're looking for anyone that's new. So we're continually noticing residents that are below the radar for fluids. And we can't just chase the numbers. We have to use our minds and our nursing judgment. In this building especially, several people who show on that list could be because they haven't even been here 72 hours. So you don't even report them. They're showing up because the computer's doing what we asked it to. It's telling us that in 3 days, they haven't had 3,000. Forget that they only moved in last night. So you want to be noticing that too and sorting out who's really at risk and using that information. So that's the main thing. Prioritize. Know which of your residents are in most trouble. Know who's circling the drain. Know who's heading downhill. Know who really needs to be watched carefully so that you can be intervening appropriately. Again, you can't possibly do it for everyone, but you can do it for those people that are the most at risk. Care tracker widget, they're called widgets, no one knew that, but that's the little thing that we see in Care Tracker that tells us that these people took less than 3,000 cc's in the last 72 hours. So with that, I'm going to escape this and we'll actually go into Care Tracker and I'm going to show you a few things. And I want to go home. Oh, it's making me sign in again. Sorry.
You were out for so long, probably.
Yeah, I see that. I'm waiting for it to boot. It's not going to do that if I'm not logged in. Okay, There's the widget. You see down below, the one we formerly used, and it's still in there, less than 1,000 for 24 hours, and then less than 3,000 for 72. I'm going to go to manage facilities, so I'm sure that we're only looking at your facility. And we go from 18 to 10. Click on it.
The two that show up on my unit aren't even here. One's in the hospital, and the other one went to Hg Poc.
Well, they should have been taken out of the system. So it's loading. So, but that's the kind of thing you know when you're looking at, so you're not sweating about them because they aren't here. Although, if you moved them, but they're at risk, that should have gone with their report. So if they went yesterday, but they are at risk for dehydration and they are low on fluids, you let them know. So anyway, it's loading. But it does tell you. It hasn't taken this long. Hold on. It says it's done. And it's not. Let me close it. I'll try it one more time.
See, I don't click on that, because I don't like it. I go down to, I click over to reports and go down to the line, the written, that stuff that's written out.
Whatever way you do it. Just so you
Because I have that same problem, I go to click on that and nothing shows up.
Well, and the other thing I learned today, in the widget, the supplements are not included. But it doesn't matter for everyone because not everyone has supplements. But yes. So we've been talking, Diane's been talking to Care Tracker today, and that won't be much longer. They're working on it right now, making sure. Why wouldn't you have all the fluids consumed going into the widget? So anyway.
Half of their meals, a lot of them are on fluids, so.
Yeah, so you wouldn't get that.
Yep.
So, when this shows up, it gives you a list of residents that are under 3,000 cc's, starts out with those that are the highest, like 2890, and goes all the way down to someone with only 300, but that's because they only came in the last shift, or because they're at end of life, or whatever the situation is. So that's where we find that. And then I'll show you something else if it works. You see these tabs, and this is something that will only go through unit managers, but I want nurses to be aware that it's available so you can talk to your unit manager about it if you think it's necessary. I put something in here under the Care Tracker tab, under Change Scheduling Information, Corporate Secondary Additional Fluids PO. A primary assessment in Care Tracker is one that you put in and it lights up a yellow button for every resident in the house, like ambulation or bed mobility or whatever it is. Something like additional fluids, you don't need to give it in the house, you do a secondary. And that's one that can be added resident by resident, only for those who need it, for a certain group of people or one person. So this is here, and this will give you a yellow button that would say offer 120 cc's additional fluids PO, total of 2 occurrences, more than 4 hours between, so it's 4 hours. Every one day from 6 in the morning until 2 in the afternoon. So this is fluids in addition to breakfast and nourishments and snacks. Because we already are adding those up and they're not enough. So if we're saying extra fluid, it's got to be extra on top of that. So you could put this in for day shift, and there's one for evening shift that starts at 2:30 p.m. and goes till 10. And if you did both of those, there's an extra 480 cc's right there. Because what do we tend to do? We say, push fluids, give extra fluids. It's too subjective, it's too vague. If you plug in actual numbers, you know exactly what you can expect to get in or what you're aiming for. So you want to put that in there. If you believe that your resident, they're not that far behind and they do okay during the day, only choose the evening one. I'm also not really down with the every 2-hour thing. It's like you never stop. And actually every 4 is almost like you have your food before breakfast, then you get breakfast, then you get lunch, then you get your other food. So it ends up being roughly every 2. And I wouldn't wake anybody up for fluids every 2 hours overnight. They're, just like the resident choice thing. You're waking someone up from a dead sleep, drink 60 cc's. I mean, how often do they really do it? What I told the night, so what we want to do though, if they're behind, we want to try to capture that during their waking hours. It's more important to make sure we try and do that. And I told night shift, I don't want you waking people up for fluids, but if you have that restless person that's following you around on rounds or sitting up in the jerry chair all night or give them fluids while you can. Get all fluids into them that you can and measure it. So that if we get them to bed and they sleep half the day, at least we know they got 600 cc's during the night. So take advantage of the opportunities, but I wouldn't wake anybody up to make them drink. We should be able to capture that during the daytime. Okay, so that's it for that. Then we go back to our thing. So we went to the Care Tracker tab for the Care Tracker main menu. We clicked Change Secondary Information, Corp Secondary Additional Fluids PO. Select both options to offer 120 cc's Q4 hours during the day and evening shift. And this will add 480 cc's of documented fluid daily, or whatever you chose to do. We could edit it, we could put one in for 60, we could put one in for 240, whatever we think we need to do. By checking that light, you're checking that you offered it. Then you have to go in the way you
And
enter
put how
fluids and
much.
put the
So-
fluid in. Yes,
So if you offered 120, but then they decided to drink 240, you can add that.
that's
in.
what you would add in,
Right.
right. And offering additional measurable oral fluids in advance of signs and symptoms of fluid volume deficit and dehydration can prevent the need for an IV. When I come in on Monday and someone says, this person has a stage 3 that we just found, where were we when it was a 1 and a 2? Same thing with dehydration. It's great that Tony got an IV, but it'd be better if we noticed that Tony was heading that way 2 days ahead of time so Tony could have had extra PO fluid so he never had to have it. IVs are labor intensive for us. They're invasive for the resident. They put them at risk for infection. We have to worry about them pulling them out. If the person can get adequate fluids in under their own steam, that's always going to be the preferred way, and we want to be on top of it before we get to that
But
state.
they wouldn't take it in.
Well, and when it gets down to an advanced directive kind of thing, then that's up to the unit manager and the social worker and all of that.
Try.
I know. Another option you have, and I'm giving you options here, you can create a nursing order, just like the orthostatic blood pressure. Not everything has to come from Gina or has to come from Evercare. You can put a nursing order in to offer 120 cc's of fluid PO Q4 hours when awake, in addition to meals and nourishments. I put it at 700, 11, 1500, 3 o'clock, and 1900, 7 o'clock. I purposely didn't do 8, 12, 4, and 8, because then they'd say, well, they have breakfast. We're already measuring their regular meals and nourishments. We're saying they need on top of that. So I would try to stagger those times with times that you knew they actually got stuff. And again, if you sign for that as a nurse, you're signing that you offered, but you're going to have to enter the actual amount consumed in the Care Tracker. You also have choices to make about which one of these systems you want to do based on your staff and your resident. Obviously, if you do the Care Tracker one and this one, you could potentially give the resident 960 cc's worth of extra fluid. Maybe that'd be a good thing, but you might not need all of that. So it's just, you can choose whatever option you want, but those are options available to you. I'm sure the providers would love it if it didn't have to rely on them to order extra fluids. We should be able to identify when our resident needs some extra and give that when we can. Care planning is a team sport. Not all of you care plan, but it's good for you to know the process. CA, it's a something assessment. It's generated from the MDS, the minimum data set, and when the MDS nurses enter the information about the residents, have they had a UTI, have they had a fever, do they need assistance eating, it tells you whether they are actually or potentially at risk for dehydration or impaired fluid balance. And when that happens, the care plan must be in place for the risk for dehydration so that we work that through. And the registered dietitian, Jody, is primarily responsible, but again, we're a team. If the unit manager discovers that Jody hasn't done the problem 14 yet, AOD has them right out of the box that they can check off. Just get one in there, she applies it later. But we all need to make sure those things are in there, and we need to remind her or whatever we have to do to work together. We don't throw each other under the bus. We help each other to succeed because where our eye is on the prize, and that is the best health and the best care for the resident. So it really doesn't matter who does what. In your problem statement for your care plan, state the conditions related to the problem. Why is this person at risk? Because they have congestive heart failure with diuretic therapy, because they have a poor appetite, end of life, swallowing dysfunction. The different causes for the problem affect what your goals and what your approaches are. So you want to be sure you recognize what the problem is. Or they talked about a lady in the last class who's on dialysis and she's not fluid restricted, but she feels like she has to be careful with it. So she imposes that on herself. That would go in her mood and behavior problem and her fluid problem. So that when someone comes in and says she doesn't drink enough, we know the reason why. And this is what we tried out. We've had the dietitian explain to her, we've had the dialysis staff explain to her. Whatever the situation is, you want it to reflect in the care plan. State a realistic goal, such as the resident will not exhibit clinical signs and symptoms of dehydration, or they will consume greater than 3,000 cc's in 72 hours, since that's our goal. And actually 3,000 in 72 hours isn't all that much. It's quite a low, it's kind of a low hanging fruit to shoot for. So you really want to exceed that if you can at all. But, we ought to be able to meet that. That ought to be a measurable enough goal. Put solid, measurable interventions in place. Offer an additional 120 cc's. What you're putting in that MAR and what you're putting in that care tracker should be in the care plan too, because that's the mother document. That's where everything else is coming from. So you want that in the care plan. And then if something changes, you want to change it up. Review the med list to check for meds that increase risk for fluid loss and notify the nurse practitioner or the doctor. And in red, we have be sure care plan problems that are still pertinent are carried over from previous admissions. In the case of the person we were cited for, they had had a fluid care plan and they had gone into the hospital and come back, and when they came back from the hospital, the fluid care plan wasn't there anymore. And that's strange because you can carry the AOD care plan when the person comes back from the hospital, so it would have been carried forward. Someone would have had to actually DC it. And we don't know how that happened.
It happened.
But we have to notice and get it back in there. And the other point I make with that is, when we have a problem like this that we discover, maybe you've heard, we had the state in here on a complaint earlier this week, and we had a resident who's been here since 2010 with a Foley and hadn't gone to a urologist until just recently. Maybe we'll end up having in-services for that too. But when you look at problems such as that and the dehydrated person, you think, providers come in and order and make rounds on that person every 60 days at least. And we review their care plan quarterly, every 90 days at least. So how does a significant problem go on for 2 years? And in there were a couple of annuals too. So how are we all missing the ball on these problems, which Foleys are like long-term care 101. If you have a Foley, you get it out. You consider suprapubic, or you do bladder training, or you do something. So somebody there, and it doesn't matter who, has to be thinking out loud, what are we doing about this?
Well, my theory is everybody else thought somebody else was taking care of it. That's
Right.
probably what
And we
happened.
can't afford to assume.
Right.
Right, we have to ask, and we have to check, and we have to pay attention, because that's what happens, and there's really, those are our checks, those are our fail-safe measures so that those things don't happen.
Good question. You said that the nurses can put on the MARs to increase the fluid, whatever. And then it also has to be in the care plan. So once we do that, then we make sure we relay it to the.
You're always communicating it with the unit manager so that everybody knows what's going on, right? You're discussing it together and putting it in there.
So like if it happens on the second shift, when the unit manager isn't there,
They can email,
they can just,
throw a
so
note
as long
on
as
their
it's
door.
within the 24-hour period, it gets
Yeah.
put in the care plan, we're good?
Yeah.
All right.
I'd rather have you start it and keep the person out of trouble and
Right.
take care plan it
Instead of waiting
tomorrow
for
than
the
wait till
Right.
they say it's okay. So, then pressure ulcer risk, we also had a citation for pressure ulcers. And what the situation was, is we had a resident who had 3 stage 4s and she was admitted with them. She didn't develop them here, and they were clinically improving. However, we care plan that she had a low air loss surface mattress, and when they went and checked her, she didn't have it. So we didn't have on her what we said would help her in the care plan. Was there a story behind that? Absolutely. The lady refused to use it. She didn't like it. After survey, we put her back on it, and she said, if you don't get rid of it, I'm not going to bed. But, not documented, not done. Your care plan says she has all this risk, and so you're putting her on this air mattress. If I go look at her and she's not on this air mattress, and you didn't write down why, you've got to make sure that stuff is up to date, and that all the information there is realistic in the first place, and that when it changes, you change it in the care plan. So the following residents must have a care plan problem for pressure ulcers. Dehydration was the number 14 PA from the MDS. Pressure areas are number 16. So if they triggered number 16, AOD will tell the unit manager they need this problem. Or any resident with a Braden scale indicating a score of 16 points or higher. That's high risk. Actually, anybody with moderate risk and on should be care planned for skin. Any resident with an actual pressure area, whether they were admitted with it or they developed it. If they were admitted with it, they're at risk for that pressure area worsening or becoming infected, and they're certainly at risk for additional pressure areas. And if they developed it here, then we have a problem. You know, what did we miss about offloading them when they first were reddened? What did we miss about positioning, or that they had a brace that was rubbing their arm, or what the situation was? And any resident with a diagnosis of diabetes or peripheral vascular disease, they're automatically at greater risk. So you want to make sure that they're care planned. Both dehydration and pressure ulcer problems, we want to be sure to make adjustments to the care plan with any changes or improvement or decline. Review the care plan thoroughly every quarter to be sure that updates are not missed. Maybe you had a change to a fluid restriction or a newly ordered fluid restriction. And we've been talking, as we've been researching for this in-service, we're finding out that a lot of our residents on fluid restrictions aren't even getting as much as they could. That's a fluid maximum. And they may have a 1,500 cc fluid restriction, they're getting 990 for 24 hours. So it makes everyone so very careful if you don't measure those amounts and separate them so we make sure the person gets their 1,500. They're running even drier than they need to. And it may be that some of those residents could drink all they wanted to and they would never exceed that fluid restriction, so why are we all working so hard to keep carrying it over and doing all of that? So we want to get them DC'd if they're not necessary. A change in the advanced directive impacting goals of care. If you go on comfort care and you don't adjust the care plan, your care plan could be committing you to a lot of things that you don't do anymore. You're not doing all of that stuff for them any longer. Or any change in surface or newly ordered therapeutic surface like a mattress, a chair pad, Dyson to keep them from sliding, a foot cradle, heel twin, a brace, anything. You want to have it in the care plan. If they don't have it any longer, you want to get it out. If they refuse to use it, if you know that they're at risk and they could benefit from it, but they refuse to use it, that's part of the problem statement. Any pertinent information about that person gets put there. Answers on Demand, AOD, our software program, offers problems, goals, and approaches for each problem. It's nothing like you where you had to think, you just go in there and snap them right in. But you still want to edit and individualize them for each resident. It's not good to just have some canned one-size-fits-all care plan either. You want to apply it to them and then you want to personalize it. And in closing, remember the details are important. I found this on Google. It looks like it was a note by a nursing student. New bag of fluid and he farted ×3. So that's the kind of detail we want. We want every detail. And you remember being a nursing student, and I told the other group, you see nursing students come in here and they'll have a resident and they pay such close attention to them and they'll give you all this report about how they have a scab next to their hairline and they have this and they have that. And what do we report to each other on that person every day? Bill's all right, he's all right, he's all right. We just take everything about them for granted. And when a new set of eyes see them, they notice all of this stuff. So we want to be that alert to the residents who are changing and the residents who are at risk. So with that, that's our entire